Good afternoon. I'm Dr. Sarah Smucker-Barnwell, and I'm a member of the Trust Board of Trustees. I'm glad that you're able to join us today for our 28th Telehealth Community Chat. As a trust policy holder, you're hopefully familiar with our telehealth community chats. If you're not, welcome to your first one. I'm pleased to be joined again by Dr. Margot Adams Larson. So without further ado, let's get started. Margot, welcome to our 28th Telehealth Community Chat.
I am so excited to be here, and I can't believe it's the 28th one. We've come full circle on so many things, and so enjoy spending a little time chatting with you and really providing some how-to info and ethical perspective to our community. And I'm seeing a little bit of freezing, so I do want to know if it's on my side or if you notice that as well. Keep me posted as we go, but. We have some questions that we've been looking through and have some great topics for today. If you have a question now, you can feel free to drop those in the Q&A section, and we'll be perusing those as we're having our conversation today. You can also email us at telehealthcommunity@trustinsurance.com. We do these quarterly. Sarah and I are telehealth enthusiasts. We present on these topics, we engage in this practice, and we're just intrigued to have deeper conversations about all of this. And I know we've got a few newsy items coming up, so I'll toss it to you, Sarah.
Absolutely. Well, we like to go over telehealth news each time we meet for one of these chats and talk about what might be new since the last time we convened. And as of April of this year, I'm pleased to announce we have an additional state joining SIPACT. Now, just by way of reminder, SIPACT is that interjurisdictional compact that facilitates interstate practice for psychologists in the United States. So Montana was the newest to join. I believe it's enacted but not yet effective, which means you can't do it just yet, but pretty soon. So this is exciting. And, just I think that brings us to a total of 43 states now participating in SIPACT and really helps us to increase our outreach and our impact as psychologists. So it's exciting news. I don't know about you, Margot. In the last month, I've received a lot of outreach from folks regarding telehealth continuity of care and sometimes called HCon Res 14, or as I heard it in the news most often, one big beautiful bill that was signed into law on June 12th, 2025. And I think that folks reaching out about this have had some questions related to how will this impact my Medicaid clients and what does this mean for me? And I think those are important questions. And the reality is, we don't necessarily have all the answers at this moment. But we are looking for, we're looking for some things to be paying attention to. So I think there are going to be some direct impacts to consider, as well as some indirect impacts. Directly, we want to be thoughtful about reimbursement rates and what services are going to be covered. And I think most of us understand that when we work with a healthcare insurance, we're keeping an eye on these themes. So I think in our jurisdictions, and there's going to be variation jurisdiction to jurisdiction, we want to pay attention to this theme as we are thinking about working with our Medicaid clients. Additionally, we want to think about whether or not our clients receive internet access through broadband grants and subsidies, because some of these may be impacted as well. So unfortunately, I don't necessarily have a direct answer for folks making this inquiry, but I would encourage. Dear, it looks like we may be getting some freezing. Is that the case, Margot?
Yes, I am seeing that a little bit on your side, so we can do a little problem solving. I would just add into this aspect of a conversation that it may also be that different states and different jurisdictions have different impacts or implications. And so for those of us used to having connections with our third-party payers, it's going to mean having more phone calls or office staff having more phone calls to check in with those providers for insurance reimbursements to see how that may or may not impact you. And as Sarah was describing, we know this is coming. We don't have any answers for it at this point, other than to say it's really key to just make sure you are doing your due diligence of checking in your jurisdiction or the states that you may be providing care services under in terms of Medicaid or Medicare.
Great. Let me know if I freeze again. We have some alternatives we can try.
All right.
So, additionally, another question I've received in the last few months relates to GLP-1 agonists. So, these are medications like Zepbound or Mounjaro or Ozempic, had a primary indication for type 2 diabetes management, but increasingly we're seeing some folks use this for weight loss. And I think this is one of those things I think is really relevant for those of us who work in behavioral health or behavioral medicine specifically. I know one of my first roles as a psychologist was at the VA in a gastric bypass and bariatric clinic. It's the only place I ever did aerobics at my psychology job. So that was neat and special. But I think there's been an interesting secondary literature emerging that find other impacts, such as a reduction in alcohol use, a reduction in problematic gambling. I don't think the literature is there yet to necessarily indicate this medication for those primary issues, but I always ask a client what medications they're using as a very standard issue. So when I see one of these GLP-1 agonists, I'm seeing them more because my clients who see me over telehealth receive telehealth services elsewhere. And what we're seeing is that these GLP-1 agonist medications are being increasingly prescribed via telehealth. And so as we see more and more people using the medications, I'm finding a lot more intersectionality with my practice. So it's one of those things I'm always certain to ask about and to ask whether or not they are using them, how they're experiencing them, and what they're using them for. Maybe it's for the management of type 2 diabetes, or maybe they're on a weight loss process with their doctor. It's one of those things that, I'm asking more about. And I mentioned it also because I had a few questions. Well, can prescribing psychologists prescribe these? And generally speaking, no. This is not under our scope of practice, the medications that we prescribe, but it is an interesting intersectional question. So, okay.
I
And how
think
are you? Oh,
that,
please.
I was just going to jump in and say probably one of the number one questions or topics that I've had conversation with fellow colleagues about has to do with AI. And this is going to be one of those ongoing, continuing conversations. I would refer folks to some of the recent presentations that have been done through our colleagues to get a little insight onto what is burgeoning, what is coming, and how we need to be thinking about it related to the technology in our practice and what may or what we may not be aware of happening with the technology in our practice and its use of or access to AI in support of what it does. So
Yeah.
that's just one of those things that might not be as much a newsy item, but it's something that is definitely on people's minds and something we'll be watching as we go.
Well, and we had as part of our Business of Practice series on May 5th of this year that Harnessing AI for Good. So it's now in our on demand library, and folks who want to do a deeper dive, she did a wonderful job, and I would point them to that content.
Awesome.
Great. And
Well,
how are we
Sarah,
doing for freezingness, Margot?
I think it's a little better. I haven't seen quite as much freezing. I'll keep you posted.
Great.
And I know I see there's questions coming in. Keep them coming in the Q&A. And we had some questions from before that related to how we navigate certain topics as we're providing telehealth care. And Sarah, I know you've been brave to jump in and highlight some details in terms of areas related to sexual assault within a telehealth practice. So I'll let you kind of take that on and I'll monitor the Q&A for our questions to come.
Great. Well, recently, in the past several months, there have been several publications, notably a multi-year peer-reviewed study that looked at almost 500 cases in rural and urban hospitals in Pennsylvania and Washington state, I believe, of sexual assault survivors who had come to the emergency room for care. In this protocol, I believe Telesane, it was called the Telehealth Sexual Assault Nurse Examiner Protocol. Consultations were offered to those survivors either in person or via telehealth. And I think what we found was that, and they could also have both, I believe, and the adoption rate was incredibly high. Over 90% of people offered that telehealth consult took one. And what we found was that overall, very positive engagement with the protocol. And so for me, this highlights telehealth's acceptability and potential when survivor centered principles are used effectively. And I think what we know is that people were feeling more secure. They felt they had improved confidentiality. They felt that they had more say over where their care happened and when. And I think if we think about whether they were in ER, people were coming or going, that that was a superior circumstance for them. And so I think that this, to me, one of the most interesting questions is not just when telehealth is as good as care in person, but when we can offer something additional. And I think this is a nice example of where we might be able to offer something additional for clients. So, this is a circumstance in which they maintained quality, they followed certain protocols, care outcomes were comparable to in person conditions, and survivors reported increased feelings of autonomy, confidentiality, dignity, and control in their care. I think it's a very exciting study, and I wanted to highlight it because it is a question we receive from time to time. Is this an appropriate modality in which to serve survivors? I think it's exciting, and an expansion on how we thought about serving people previously. So I just wanted to bring it to the fore. I think all of us in behavioral health are going to be looking as to like what this means for some of our best practices. This was a nurse practitioner focused clinical study, but I think it has a lot of implications for us moving forward.
And I think it's really interesting to make sure that we're considering these aspects because from time to time, we might not recognize that that's the outset of how we're starting in our clinical case scenario, but it may be something that develops during our course of treatment with our patients. And so being aware that these things can find themselves in your practice, even if that might not be your initial thought or consideration as you're starting out with your patients. So helpful to have some guidance and ideas of where to move and how to inform your care once that arises.
Absolutely. Well, I've seen some great questions in
Yes.
our chat. And Margot, I am going to change my Wi-Fi to make sure we don't have any more freezes. So why don't you pick one and we'll get to answering it?
All right. So, well, one of the ones that I was seeing here is a very easy one to at least give some guidance and ideas for initially, and not specifically related to what Sarah was just talking about. Do you have thoughts or experience with cyber insurance? And this one we do get from time to time, and I have done a little digging into this. And my recommendation for folks who are wondering if this is something that would be important for their practice or that they need is to really call into the trust that offers cyber insurance. You can call in to get information to review what your practice needs are and determine if that is something that you have a need for or not. And that way you can get your direct question answered as opposed to us providing more specifics at this point. Generally, if you are involved in navigating an organization or a large practice, or you have a lot of interaction related to technology, housing, or storing data or information, those are things that you'll want to have a little bit of an audit about so that when you call in, you can have some answers ready for the questions that they may ask. So hopefully that gives a bit of a guide to how to find out more information about cyber insurance. Sarah, do you see other questions that you think would be good for us to cover?
Let's see. How do we compensate for the loss of body language monitoring or other nonverbal observing when engaging via telehealth? Such a good question.
That is a great question.
I mean, and I think it's one of those things where I just want to acknowledge there's not necessarily a perfect solution. I'm happy to share what I do, Margot. I'm always curious what you do.
Yeah.
Um, I try to, as best I can, ask folks to, well, a couple things. If they're right up against the camera, I ask them to sit back so I can see a little more of them. Also, it gets a little strange if you're that close. I might ask them to scan the room so I can see their environment a little bit. Additionally, I think I just slow down and ask lots of questions. I perhaps rely more on structured clinical interview questions than I would otherwise because I can't see that twiddling thumb. I can't see that tapping foot. Um, and so I think I rely a bit more on just not making as many assumptions, which is hard because we're not always aware we're making the assumptions. But personally, I slow it down. I try to be really intentional about the questions I ask. And I might ask some very somatically oriented questions that things like, well, how are you feeling in your body right now? Or, how is this going for you? Do you feel muscular tension? Things that are a little unusual to ask. But I try to be really explicit about this inquiry. So how about you, Margot? How are you solving this?
Well, I have found myself asking third-party questions. I'll label them that way. Has anybody ever told you that you chew your nails or have a nervous tap, or do they ever say, stop thumping your leg or your foot? Because those are things that I can't necessarily see. But if they're happening frequently enough, oftentimes people will have made some comments. So it's another way to gather some of that information. Also, a lot of my practice is pediatric. And so I have seen a lot of tops of heads and up nostrils and bottoms of tables or the top of the table. Things that are parts of the environment that are not the patient themselves. But because they're moving either the computer or the phone that they're linking in with. And so sometimes like you, Sarah, I will ask for them to put the camera in a farther away location so that I have a bigger, broader picture of the whole environment. I can sometimes grasp then the connection between what's happening with maybe a parent that's also present in the room and the interaction that they're having. And so rather it be only singularly focused on one person and then another, to really back that space out so I have a bit broader view. And it does get tricky because they want to see us too, and they want to see us up close, and we're usually on the same
Yes.
device and not on a camera that's able to be placed somewhere else. So there's some give and take with it, but it is um, for me something that I've become a lot more cognizant about in the square screen of seeing folks in practice as opposed to what we might be privy to within an office setting. Great question.
Should we do one more?
Sure. Do you see another one? I'm just scrolling down.
Are there different rules and guidelines for telehealth when psychologists operate in a coaching capacity? And can you recommend any resources addressing this topic? Really, I'm just cheating because I happen to know that's your next topic.
That is a great segue. I'm not going to spoil the answer, but I will segue actually. This is a topic that we have had a lot of questions about over the different chats. We've actually had folks email in these questions about coaching practices, and Sarah and I are kind of nervous to share a lot of detail in this topic because we know you want it, but we also know that there is a lot of unclear guidance that we have in jurisdictions, and I'll explain that in a little bit. It's also kind of an area where a lot of folks, maybe the lines can be blurred a bit in terms of what is coaching versus what is psychological practice. And we also see a lot of folks that are doing coaching out in the wild that are neither a psychologist or trained in mental health, but they're coming at this from a different capacity. And so I think thinking about all of those things, I want to respond to this question and just kind of talk about this topic in general from the lens of psychology and coaching and or psychology versus coaching, and not thinking about some of those other folks that may also be in this space. And we're certainly not talking about the football or the NHL coaches in their scope of what they do. But there is an important distinction in thinking about how we might define or clear the lines between psychology practice and coaching. Coaching is not therapy. It's meant to focus on enhancing performance. It's meant to focus on goal achievement, on well-being, and in non-clinical populations or for non-clinical purposes. So, for example, the population might be CEOs or executives of corporations. It might be students who are athletes and wanting to have peak performance. Or it might be parents who are interested in achieving things for their family in a manner that has nothing to do with a clinical diagnosis or a treatment protocol. And psychologists have a lot of techniques that might lend themselves well to coaching. Or said another way, coaches might use strategies that we may have found through a mental health treatment protocol in terms of the work that we do as psychologists. And it's really key that we are not, as psychologists, that we're avoiding or not providing mental health treatment under the label coaching. This could be seen as unlicensed practice or for sure a misrepresentation of what you're doing as a coach or as a therapist, particularly if you're crossing state lines in terms of delivering these services. And as a psychologist, if you are engaging in coaching, you want to have some very clearly defined kind of process or consent forms that are very separate, that are individual to the function that you are engaging in, whether you're doing treatment for a disorder with a clinical diagnosis, with a treatment outcome, or whether you are coaching an executive to do better in their job performance and achieve their next rank or next career goal. And so really key to not mix these roles within your practice. So if you think your client as a patient may that you're following, for example, for anxiety, might benefit from some executive coaching in their work environment, refer them to somebody else to do that executive coaching in their work environment, as an example. In terms of licensure and jurisdiction, it's important to realize across either jurisdictional lines, whether it be state or international, that psychologists do need to clarify the work that they're doing, and that they are, if they're doing coaching, that they're not providing psychological services, and that they're not practicing in a jurisdiction where you need a license to do coaching, or or you already have a license in that jurisdiction to do coaching. And it's not really clear in all psychology law whether or not coaching is part of the scope of psychology. Some jurisdictions are clear on this, others are not. And there are some states where the practice of coaching is actually regulated in certain forms or manners, depending on the person doing the coaching. And it's not always easy to find this information. So it really is just a reminder that SIPAC is not there for you to do coaching services through. It's not part of the scope of the SIPAC model. And so if you're engaging in coaching, you do need to do your due diligence and homework in each of those jurisdictions that you may be practicing into, as well as making sure you've got some clear disclaimers about the nature of your coaching, particularly as a telehealth service. I did mention earlier that you want to be particular about your informed consent or service agreements and what is included, and that those are separate when it's a coaching service agreement. And um, what you include in that coaching service agreement, what you don't include in the services you provide, that it's not a substitute for therapy, what your fees are, what the limits are in terms of either your relationship in how the connection or communication expectations work, or when you're going to meet and what the boundaries are, and also any confidentiality limitations that you may have as a professional and or that may be in place. Coaching isn't protected by HIPAA rules unless it's occurring within a healthcare setting, and there still may be some nuances to that that you really need to dig into and understand. But there may be some other confidentiality limitations that you have as a licensed provider, which might clump you under mandated reporting in ways that you might not think about on the fly, but you sure should consider before you're engaging in your coaching practice. And those should all be documented, just as we've talked about in other ways, in informed consent for your coaching services. Also, different business structures or entities for coaching can sometimes further detail how you might be providing those services or what boundaries may be set for that as well. You always want to be thinking about privacy, and if you have HIPAA compliant video platforms that you utilize for therapy, that may be something that your clients from a coaching standpoint are expecting. But again, you want to have very distinct practice entities between your electronic health platforms and records that you might be utilizing for therapy versus the ones that you're utilizing for coaching. Setting those expectations early, establishing your location and how you might troubleshoot any connection problems, particularly thinking through any other jurisdictional requirements, particularly for international clients that may come into play, such as the European requirements in GDPR and any other legal consultations that you might need to look into for that. As always, you want to have training. You want to know what you're doing and what that distinction is between coaching and psychology. We go to a lot of school to learn about the psychology side. Having a little bit of informed information from a coaching specific training program might be really something to consider if that's what you're looking to do in addition to your psychology practice. There are a lot of useful techniques in executive coaching and life coaching or performance psychology that certainly can blend across those domains, but you want to be clear on who and when you're using those and what hat you're wearing when you're providing that service. There's also some organizations that are known for credentialing, such as the International Coaching Federation, ICF, and thinking about what credentials you might want from a coaching standpoint and or what ethically might align for you in your coaching practice. Overall, one of the most important things to make sure on is your marketing and representation, and that you avoid implying that coaching is a regulated or a licensed service unless it is in the jurisdiction that you're working in, or unless it's integrated and that you're actually utilizing that underneath your therapy license. And again, the lines can be really blurry. And so making sure that you are very clear on how you're presenting this to others, how you're presenting it on any of your marketing materials or your website. And if you're providing coaching, that you're not utilizing terms related to licensed practitioners, such as psychologist. Psychotherapist is sometimes a regulated term. Mental health practitioner may be a regulated term. So you really want to be cautious about the terms you're using to describe the work you're doing. And even if you can use the term doctor, record keeping, along with all of the things we've already talked about, is also key. Thinking that, ways that you're documenting and tracking the work that you do, letting your clients know how you're doing that and what the expectation is and what the minimal amount of information is that you may be keeping. And especially if you're doing this within your psychology practice, making sure that those things are kept very separately so they're not confused. Overall, I think one of the best practice recommendations that I would have for folks that are interested in doing this is getting yourself on the schedule with a trust risk management advocate so you can go through and talk through the things that you're looking to do or might already be doing, and making sure you have all of your documentation aligned with the things that you're doing, and that you're all in accordance with kind of the recommendations that the trust would have in making sure you have the best practice possible to provide to your coaching clients as well as your psychology patients.
Well, I love that. It's a beautiful synopsis, Margot. And I think for me, highlights this is another area of practice, where it's confusing, and I think that I think there's certain kinship to telepsychology in that we want to be extra thoughtful, extra conscientious, really know our boundaries, really know, when we're doing what service, and document, document, document.
And we didn't even mention insurance, but perhaps it goes without saying, this is probably not something you're going to be filing with your patient's insurance company.
Well, should we take a look at some questions?
Sure, let's see what we have.
We had a couple good ones about AI, and I wanted to call one out because I thought was pretty interesting.
Go for it.
Asking about AI and note taking. So
Yes.
I have, like many of you, an electronic health record platform that I use, and they are teasing, they're sending out messages saying, hey, in 2025, we're going to offer a clinical note taking augment or module for your practice. So this is something very much on my mind, and I wonder if it's on yours as well, Margot. I think that a few things I want to highlight. The question I always have for the company offering this: explain to me how this is HIPAA compliant. And, explain to me, where does the data go? Help me understand how you are not consuming, my client's information in a way that is inappropriate and still going to offer this service to me. And if they cannot answer that with crisp clarity, it is nothing I am interested in. Now, I want to acknowledge there are companies that do this and do this well. And increasingly, I think we're going to see this as a standard offering in our suite of products, but it's really, we're early adopters now to using it. I know in many large healthcare systems in Seattle, it's standard. You have Scribe software that accompanies primary care doctors. So I think we're going to see increasingly in behavioral health as well. But before we have this totally codified into our practices, into our software offerings, I know I'm going to be very fussy in inquiring about how they are balancing these demands. Anything you'd add, Margot?
I would add my typical disclaimer, which is just because we can doesn't mean we should, right? And what I find is these nuggets that they drop about, oh, we can take your notes for you, sound convenient and sound great. But the challenge that I have is ultimately AI is not a regulated licensee. Ultimately, we are the licensees who are responsible for keeping our notes according to ethical and clinical guidelines. And I can see a slippery slope of relying on, and I see this actually in my doctor's office, right? They rely on the scribe to do the stuff and no one goes back to check. And they don't go back to check because when you review it, you see the error of what wasn't said or misspelled or got completely wrong. And I have great concern for folks that are seeing this as a way to be uber efficient within the office setting, and not recognize that we still ultimately have that ethical responsibility to review it all. And so I think proceeding with caution,
Mhm.
I love your guidance on that. It's key. It's certainly coming, and finding ways for us to utilize it in the most ethical and um, supportive manner for our practice is going to be really important, in
Yeah.
addition to all the things you mentioned.
I mean, and I should say, I'm also excited. Like, so I definitely have all this trepidation. I have all these concerns. I'm not always the customer I suspect they like best. I'm also excited because I appreciate how, in some ways, this could help me be more present, more attuned to what's happening in the moment. So I worry I sound a little phobic when I talk about it because, I'm here in a risk management capacity and I'm worried about some of the ways these can be applied. I also, unabashed telehealth enthusiast, I'm excited about what this could offer in terms of my ability to just listen, just be present, and not worry that I didn't write down that the cat's name is pajamas, that's going to be there for me later. Um,
Right.
you know, no HIPAA has been broken, no cats are named pajamas, in my practice, but I think there's something there for us.
I don't disagree. And I think we probably could have had the same conversation when we first started recording sessions, either by video or audio tapes back in the day. And so, yeah, I think it really is that, there's a certain amount of early adoption that has to occur for us to get to be able to navigate and understand some of the complexities that we can't contemplate without trying it. But I do think I feel that excitement, but I also feel a sense of caution, a lot
Absolutely.
of caution.
Absolutely. I saw a really interesting question about, oh, and of course I've lost it. But the ethos of the question was, hey, there sure are a lot of telehealth laws interjurisdictionally. Who's
Mhm.
solving this problem? Um,
Ooh.
Great question. I know we at the Trust are definitely, it's something we're interested in, we talk about. And certainly when you talk to our advocate program and the risk managers and give them the specifics of your practice circumstance, that's to me, that's the chef's kiss because it's not just a general, now they're not attorneys, they're risk managers, but they can drill into like what resources are bespoke to what I need for my practice. But broadly speaking, I do like to mention two things. One, telehealth resource centers. These are regional. So you'll have one for the West, you have one for the East. You can Google telehealth resource center near me, and it should find you some links. These centers offer resources to help coordinate the laws in a given area. Now, if you're like me and you just want one stop shopping, there is an app from Epstein, Becker, and Green, and I will put this in the Q&A in a little bit so that it will be there. I'll put it in our chat. But it is an app that they do a reasonably good job updating that goes over all the telemental health, excuse me, I should say, laws. Now here's my asterisk and my caveat. We just don't know. I can't promise that that is going to be updated in a way that, today it might be, but tomorrow we don't know. And I think that is why not every organization is running out to solve this issue, because as soon as you opine, tomorrow you'll be wrong. So a law will change, a new practice case will come through that will, alter the ethos of the practice board. So for now, my best recommendation, and it's not an efficient one, is like know your local resources, check that Epstein, Becker, and Green app. Those are all good resources. But at the end of the day, check your board website, check the Distant Sites board website, make sure that you have a mechanism for practicing interjurisdictionally and appropriately. I did a 3-hour webinar for the Trust and for the Register this year that's on their on-demand content that really dives into like what are the ways I can practice interjurisdictionally appropriately, not get in trouble. And there are ways to do it. We just have to be really thoughtful. And honestly, if you just want to be certain, you check your board's website, you check their board's website, and you learn the differences. And it is not an efficient process. And I'm so sorry.
Well, and I just want to add to that too. It's an ongoing process. It's not just today, because like you said, the laws change, and the laws change typically April, July, and a December time. Those are some that don't hold me to those exact dates, but those are times where the laws from the last session get promulgated and move into being active. And just like Sarah said at the start, we have a new state coming into SIPAC, but it's not enacted, or it's enacted, but it's not effective yet. And so there's time, things take time to roll through the legislative process and become law, and they change in nuances. So just because you looked at it in January doesn't mean it's still the same in October when your patient actually moves to that far off place wherever they're going. And so this is a constant upkeep, and that's part of the challenge that a lot of organizations have in navigating this question as well.
I saw two additional questions that I want to sneak in. One asked, I thought this was such a smart one, and I believe it relates to an AI note taker. How can I be certain, if I consent to an AI note taker, that my content isn't being used to train an LLM, a large language model, basically to become a future AI therapist? And I just want to say my assumption is it is. I mean, now, in which this is happening in other ways, and that this, this is happening, right? And I think it's a really smart question. It would be among the questions I ask a vendor if they want to implement this in my software. My assumption is yes, it is. They may be handling the data in such a way that they regard as HIPAA compliant, and that I would leave that question to an attorney and not me. But I just assume that that is what's going to be happening because they want to augment, their LLM. They want the best bespoke LLM. And in some ways, what I say is my intellectual property. That's what I do. So I think there is a question of, do I want to give that away? I think it's such a smart question. And then just to keep on going, we had a SciPac question, which I thought was a really smart one. This was something I learned recently. I had to seek out the answer, make sure I understood before I did the webinar. SciPac enables you to provide telehealth from your home state. So you designate your home state. Is there a way to legally provide telehealth if you're in a different state, but clients are in your home state? And now I'm talking about only through SciPac. There may be ways not through SciPac to do that, but from a SciPac perspective, no, not unless you also have a license in the home
Yeah.
state you're sitting in. So in SciPac, your home state is where you're behind is sitting in your chair, excuse me to be so coarse, but they want you to be licensed in that home state. So if you're trying to do it through the SciPac mechanism, then you want to be licensed where your home state is. It's frustrating, because people are like, well, gosh, wouldn't it be better if I could just change my home state when I go on a week's vacation, something like that? And unfortunately, through SciPac, no, you have to be licensed in that home state. Now, if you spent half your year one place, half your year in the other, and you enjoyed having SciPac, I think getting dually licensed in addition to SciPac would be a great mechanism. If you're only practicing in those two states, I don't know what value SciPac would add, but maybe it's an additional protection. But I could imagine if I had a telepsychology practice that went to 3 states, but I really only went to 2, dually licensed in the 2 I sat in, and then, SciPac for the third would be a smart strategy.
And just to add on to that, if you are licensed in 2 jurisdictions and you are traveling between those, SciPac does have a mechanism where you can indicate each day where you're located. So you can switch your home state.
It's really easy.
It's easy to do, but you do have to have the license in those different jurisdictions.
Just go to their website, you click a little button. It's very simple to do, but you have to be licensed. Otherwise,
Great question.
Yeah, great question.
All right. Should we move along, Sarah?
Sure. Well, another great question we often get in our feedback relates to suicide and remote care. We're hitting a lot of the serious topics today, but we get this almost every time in the comments. It was also a nice opportunity to reference a recent webinar we had on clinical suicidology. I believe it was June 26th, and it should be available on demand soon. So there was a really nicely done, Dr. David Jobs did it if this is a topic you want to dig deeper into. But again, we used to always ask this question, is telehealth safe enough for such a serious area of practice? And I think we have to date well answered this question in the literature of saying, yes, that this is an appropriate standard of care for clients with suicidal ideation, with the caveat, you never have to provide care that you don't feel appropriate providing. So is it among a best practice you could do? Yes. Do you have to? No. But for me, the research is there that suggests that this is an appropriate way to treat clients with suicidal ideation or past behavior. And indeed, it used to be telephone hotlines were a standard of care, when someone had ideation. But I think that in recent years, we've broadened our gaze, again, not just to ask if telehealth is non inferior, but are there moments when it could offer something in addition where we can do more for our clients using this technology? And I think there have been some in the last year or so, some really recent articles that are promising. Baker et al. I know people have been asking for citations. Baker et al. Had a JAMA article about a year ago talking about a brief cognitive behavioral therapy intervention over telehealth. They did a randomized clinical trial and found that that CBT intervention, that brief CBT intervention delivered through video telehealth, significantly reduced suicide attempts and even ideation over a 1 year follow-up period. And this was a comparable outcome to the in-person care, but notably for some people, they said, this is care I wouldn't have received otherwise. And I thought that was really exciting. When we are impacting people's lives that they wouldn't have gotten the care otherwise. Because to me, that's where we're going beyond. Similarly, there was a meta-analysis, Shoib, Shoib et al. In 2024, that looked at telepsychiatry interventions and effectively reduced suicide rates and reattempts following an initial attempt. These were, again, the interventions were really well accepted by the people in the study, had a very high retention rate, actually better than some in-person conditions, and suggests again here that this is a viable way to provide care that people might not have received otherwise. So anytime we are assessing suicidality, we want to be thoughtful, structured, evidence informed. The physical distance and the potential limitations that we talked about earlier in observation, these are heightened in the telehealth condition. And so I think we want to be really, really thoughtful because not only is this an incredibly important area of practice, but the reality is in telepsychology, there's something of a fishbowl effect. We're really cognizant. We're additionally conscientious and cautious in an area that's already incredibly requiring a great deal of caution and thoughtfulness. So I really encourage us to go back to those best practice basics. We use a structured tool for suicide risk assessment. I personally like the Columbia Suicide Severity Rating Scale, Columbia Suicide Severity Rating Scale. And this is a validated tool for the assessment of suicidal ideation, behavior, risk. But even that old PHQ-9, which I see everywhere, I see it at the primary care, I get a PHQ-9 at the chiropractor, that has item number 9, which inquires about suicidality. So it doesn't even need to be a large measure, but using, measures regularly as part of our practice, and then a structured suicide assessment measure. We want to supplement these metrics with open-ended questions, of course, about intent, plan, means, protective factors, and we want to create a plan with our clients. Again, not a contract. Research has shown us contracts are not particularly effective, but a plan that includes what is this individual's warning signs? What are their coping strategies? Do they have support contacts? What are their crisis resources near them? And what is the plan together between psychologist and patient to help to help respond to these warning signs, and of course, always reduce access to any lethal means and make sure they're getting the resources they need in a timely fashion. We always document in these instances and in telepsychology, perhaps additionally, we know where the patient's located and their emergency contacts. And we find this out before there's an emergency. That's why it's part of our intake process. We decide about a safety plan and how we would respond to an emergency before there's an emergency so that I'm not trying to figure that out in the middle of an emergent circumstance, which would be stressful for patient and provider. Ironically, I have a note that says, note any disconnection or technological disruptions. Say there's a storm happening outside that disrupts your technology. You want to have a redundancy plan and, make sure if the internet goes out, how am I reaching out? How am I getting in contact with this person? And we talk about that in advance. And we want to know, is there a support person that we would call? Do we have a release of information to do so? Now, in many instances, we might not, the law might be permissive in allowing us to reach out to that support person. But personally, why not have the ROI? I like to have the ROI. Just there's no questions. We agreed in advance. This is what I was going to do. I was going to contact this person. You said so. So nobody's surprised. I remember there was a survey APA did years ago that talked about litigious circumstances with psychologists and saying surprise was a really big factor. We don't want to surprise people in difficult times. So these are some of the standards. Again, I encourage people to go to the suicidology webinar, which does a nice deep dive, but I wanted to mention some of the cool cutting edge stuff that we see on the horizon. Voice biomarkers. There was a study in Australia, Australia loves its telehealth, of about 300 telephone calls that identified some suicide risk among the clients using voice biomarkers, and they think they had 11 or 12 of them. 99% accuracy could an algorithm predict disclosure of suicidal ideation intent plan using those voice biomarkers. That's amazing to me. I mean, we're talking about all these notation things and they're training the LLMs, and oh my goodness, what if they could add some clinical utility? It's an interesting question. Again, I'm not signing up today, nor is it offered today, but it's interesting. It's something I'm going to be paying attention to. Smartphone monitoring, and I actually used to interact with a company that did this. Research looking at smartphone engagement, looking at the data. So, what apps are you using? What are your step counts for the day? Are you calling people? Are you texting people? Hi Sarah, it looks like you haven't moved from your bed in 3 days. There's a lot of data, for better or worse, that we are offering through our smartphone. We're using it to be marketed products and sold things. What if we were using it to save our lives? And so I think there are these algorithms that use these data that can, with surprising accuracy, identify suicide risk and even hospitalization risk. And so I think that these are things on the horizon. Again, it's not today, but I like thinking about these things. I think it's going to be a really interesting question of when and where we use these technologies to make our patients more safe, and to make sure that we are practicing in alignment both with confidentiality, privacy, and doing the best we can for our clients.
Sarah, I love that overview, and I'm excited about the things that are coming. All of this, to me, speaks to having some data behind, not just the conversations that we're having, but having some consistent questions that you can ask your patients, that we can follow up with each time to not just see the progress, but also alert us if something is maybe new on the horizon that wasn't there previously. And just because they might not have been suicidal at intake doesn't necessarily mean
Right.
that that might not pop up at some point during a
Right.
treatment session or time in terms of a protocol. So
We
thank
know
you.
people change. We're psychologists, right? Like
Yeah.
it's sort of our thing. Yeah.
But we also like them to be very consistent.
Period. It's not the change we're looking for, but it is like I think we better than most, understand professionally that, you start one place that may not be the place you end up, and our ability to be present with that, and constructive and compassionate during those changes is incredibly valuable.
And I do feel that there's a lot coming in technology to help support us in the work that we do and not replace us in the work that we do. I know that's often a question I get in terms of, well, maybe, the chatbot will be seeing folks and identifying these things in their voice biomarkers and they won't need us. And, we also see a ton of research suggesting human connection is one of the most powerful tools of um, the engagement and interaction. And I think part of what I love about our chats is we get to have that conversation um, sort of in person. Sarah, are there any other questions that you've seen that you want to circle back to? We probably have time for
We sneak
one.
in one more.
Yeah,
Okay. Let's see. I think some folks called out the intersectionality between industrial organizational psychology, consulting, coaching, and it's a very good point.
it is.
Um, for me, it is, for me, it is so jurisdictionally relevant, and that's such a muddy answer, and I am so sorry. But like, when I look at this, for me, there's a question. Sometimes it feels a little more clear if I'm teaching a class, to a group of executives about, hey, here's some principles about keeping a psychologically safe workplace. That to me feels pretty clear. Well, that falls under the rubric of IO psychology, that falls under the rubric of consulting. You know, versus I'm sitting down with one executive and saying, hey, you've received this feedback, and gosh, people are not liking what you're doing, and we should probably talk about that. That gets a lot muddier to me, and so I think that here, when I say it's jurisdictionally relevant, some boards treat it really differently. I'm aware of some boards on the west, even the West Coast, which we see, not that there's coastal homogeneity, but neighboring states where one state will say, oh, that's absolutely under the remit of psychology. That's a psychological service. Even if you're sitting down and talking about their work only, that's psychology because we're using behavioral health principles, and their neighboring state has opined differently. So I'm being frustratingly obtuse, I think, because the answer is frustratingly obtuse. And it is those case of, that's when I call my risk manager advocate, and I get the answer bespoke to my question. Not just I want to coach and I want to do consulting, but like I want to do it here. And I want to very narrowly define and provide this service. And in being that specific, I think we have a much more risk managed approach.
Well, and I would just add to that, industrial organizational psychology in its roots had a lot to do with changing groups of behavior within an organization or an industry as opposed to an individual. And secondly, there are a few states that do license IO psychologists. I know North Dakota has laws on IO psychology. I don't believe they've ever given a license out and nobody's ever applied, but you can go there to get one. Uh, and practicing IO within that state would require a license. So this is just an emphasis of the blurriness between all of these different areas and the importance of having yourself be very clear on who you're working with, what the outcomes are meant to be, and what it is you're doing, and having that documented well.